my great pleasure to introduce the next speaker, Tanya Siddiqi. Tanya received her MD in Pakistan and then moved to the US, where she performed residency and fellowship at the University of Connecticut, at Harvard, and then City of Hope. And she's today the director of the CLL program and supervising physicians of anticoagulation clinic. She has been and she is PI of many clinical trials, including trials with CAR T-cells. So we look forward and thank her for being with us.
Well, thank you to the organizers for inviting me. It's quite exciting for me. I almost feel like I have to start with a disclaimer amidst this very strong lineup all day long of basic and translational research with wonderful ideas and science that's being evaluated. My talk today is pretty clinical, so clinical research only. And my topic essentially covers, if I can try to advance the slide. Sorry. Those are my disclosures. My topic today is basically to talk about, what more can we do in CLL and lymphoma as far as CAR T-cell therapy is concerned. I'll start with CLL because that's really my main interest clinically, but we'll come to lymphoma, B-cell lymphomas in a minute, which basically is where we have a lot of commercial CAR T-cell products, as you all probably know, FDA approved already. So I've picked a couple of trials from each disease type to talk about, and we'll start with CLL, as I said. So CLL technically is, considered to be an incurable B-cell lymphoma. It's a low-grade chronic kind of a disease, and we know people can live for many, many, many years with or without treatment. But there is a subset of patients who really progress repeatedly and quickly, even on the novel targeted therapies. The field or the landscape of treatment in CLL is rapidly changing, but when patients progress on novel therapies, they really have fewer and fewer options, and we need some more effective therapies in that realm. So the first time I ever heard about CAR T-cells was about 10 or 11 years ago when, UPenn published on first one patient and then 3 patients of CLL who had many, many lines of prior chemoimmunotherapy. At that time, there were no novel targeted therapies, and then allotransplant as well. And we know that a couple of those patients went at least 10 years or more without relapse of their disease, with CAR T-cells still being present and measurable in their bodies. And unfortunately, I think one patient passed away recently with COVID, but the second patient is still alive. So the question is proof of concept, can these CD19 targeted CAR T-cells potentially, elicit a cure in this technically incurable lymphoma? And so that's sort of the holy grail that we all keep trying to chase. So the study that they were part of, or that ultimately came out of that initial data, is obviously pretty old now. So 14 patients treated, modest response rate, overall response rate of about 57%. But importantly, there were half of those were complete remissions and MRD undetectable, and those patients had the longest disease responses. The focus of CAR T-cells then shifted in B-cell lymphomas to more aggressive diseases, and there were a number of years where we didn't see a lot of new data in CLL. But ultimately, researchers at Fred Hutchinson Cancer Center in Seattle started publishing their work on their product called JCAR14, and that's a CD19 targeted CAR T product, which is given to patients in a 1-to-1 fashion of CD4 positive CAR T cells and CD8 positive CAR T cells. This was one of the studies that was published now a few years ago, relapsed refractory CLL patients. Everybody had progressed on ibrutinib pretty much or been intolerant of it. There were about 24 patients. Majority of patients had high-risk features of their disease. And at the time of this first initial study, they all stopped their ibrutinib prior to a lymphodepletion. And you can see that at the 1-month time point, overall response rate was about 71%. There were a number of patients who had had cytokine release syndrome and neurotoxicity, but there was only one grade 5 CRS or neurotoxicity event on that part of the study. And it was a short follow-up at this time point, but you can see that the blue line on each of those figures, is pretty flat and high, and that's the intriguing part. Those are the patients who achieved MRD undetectable responses and did not progress, at least not quickly enough. The researchers, Dr. Turtle and Gautier, then decided to add, as my understanding, add a pilot cohort to the same trial, which combined JCOR14 with ibrutinib, which, as you know, is a BTK inhibitor. Again, they tested this in relapsed refractory CLL patients. 19 patients were treated with high-risk features of disease. They started ibrutinib at least 2 weeks prior to leukapheresis, during CAR T manufacturing, and then for at least 90 days post-CAR T cells. And the reason why they wanted to test ibrutinib was because they felt like maybe there would be better mobilization of T cells, the CAR T function may improve, there could be fewer events of cytokine release syndrome, and maybe even prevent tumor flare. And they found that it was reasonably well tolerated. 2/3 patients were able to continue ibrutinib through the whole course, as I had described. They did have one patient who died suddenly in the setting of grade 2 CRS, not requiring vasopressors, but probably they felt may have been a cardiac arrhythmia related to the ibrutinib, or the whole combination, not sure. But either ways, the overall response rate was higher at 83%, and 61% achieved MRD undetectable response in the marrow. And you can see that the 1-year overall survival and PFS probabilities were 86 and 59%. And what I don't have time to show, but they have shown in their publication and presentations, is that when they combined JCOR14 with ibrutinib, that did lead to lower CRS severity. There were lower concentrations of CRS-associated cytokines. And initially it was said they were equivalent in vivo CAR T-cell expansion, but maybe even higher is subsequently what they reported, meaning higher CAR T expansion in the ibrutinib-containing arm. Out of that JCOR14, the commercialization of that product is JCOR17. And so that is the lysocaptogene maraleucel. And I was lucky enough to present the phase 1 portion of this study, which is Transcend CLL 004 trial, which is evaluating lysocell or JCOR17 in CLL patients. So patients underwent enrollment at the time of leukapheresis. They were allowed to get bridging therapy if needed. Manufacturing of lysocell takes about 3 to 4 weeks. Everybody underwent baseline testing again if they had been on bridging therapy. And then they all got fludarabine and cyclophosphamide lymphodepletion, followed by, I'll talk about the monotherapy CAR T-cell first, but the main focus of today's talk is combination, so I'll come to the ibrutinib combination in a second. To be eligible for this trial, patients needed to have failed at least 2 or 3 lines of therapy, meaning if they had high-risk features, they needed to have failed at least 2 lines of therapy, otherwise 3. And all of them needed to have failed a BTK inhibitor or at least been exposed to a BTK inhibitor in the past. You can see the baseline characteristics in the middle column of the full cohort of 23 patients. So median age was 66. Further down, you can see that they all, well, not all, but majority of them had advanced stage disease and high-risk features. They had all had prior ibrutinib, and the median line of prior therapies was 4, with a range of 2 to 11. And 74% patients had some kind of bridging therapy, whether or not they needed it. It was some for maintenance or actually to progress, to prevent explosive disease. I'm not sure. We didn't break it down like that. But the right-hand column actually pulled out 11 patients out of the 23 who had failed not just ibrutinib, but also venetoclax, so particularly bad-acting CLL patient population who really had no good treatment options left, if you will, except maybe PI3K delta inhibitors, which don't work very long or have a lot more toxicities and things like that. So there were no dose-limiting toxicity. I'm sorry, there were 2 dose-limiting toxicities at dose level 2, which resolved. And with longer-term follow-up, now we followed these patients for 2 years, actually. No real long-term side effects. And you can see that the grade 3 cytokine release syndrome was only 2. no grade 4s or grade 5 CRS events. And then there were 4 grade 3 neurotoxicity events and 1 grade 4 neurotoxicity event in the whole group. Fairly well tolerated. Lots of patients got tocilizumab and steroids as part of the management. In my experience, the biggest side effect was fever with chills, which I haven't seen a lot of in solid, meaning B-cell non-Hodgkin lymphomas like DLBCL. They don't usually get chills. They get mostly just fever. So that was a little bit different, probably because of circulating CLL cells. Regardless, the overall response rate was 82%. The swimmers plot, the bubbles show MRD undetectable in the marrow or the peripheral blood, depending on whether they're solid bubbles or not. And the first disease assessment time point was day 30. The lower half is the patients who were double refractory, meaning refractory to both BTK inhibitor and venetoclax. And you can see that in both types of patients, there were a lot of patients who went 2 years or more without progressing and maintained their MRD undetectability. There were some patients who deepened their response over time from PR to CR or stable disease to better response, about 25% patients or so. And most of the responses actually occurred at the day 30 time point, including the MRD undetectability events that were then maintained. There were a few patients who emerged with Richters in the setting of no detectable CLL. So you couldn't detect any B cells, you couldn't detect any CLL, yet there were some nodal Richters that emerged, which is very frustrating, but mostly occurred in the patients with the bad biology anyways, who were already double refractory to 2 novel lines of therapy at least. So obviously that's something we have to watch out for and improve. And maybe, earlier treatment with CAR T cells may prevent that, or combinations may prevent that, and that's where we'll get to in a minute. This is just showing the progression-free and durability of responses, but more importantly, in the paper that we published, we had figures about patients who actually had undetectable MRD, whether they were CR or PR. Those patients have not reached their median duration of response or their median progression-free survival. So in this case, we feel like MRD undetectability is very important. Coming to the combination part, now that you've seen the background, there was there is an arm on this trial that adds ibrutinib to the lysocell, and the ibrutinib, much like in the previous trial, starts at least 2 weeks or before or prior. 2 weeks or prior to leukapheresis, goes throughout, bridging therapy, and then for at least 90 days after CAR T-cell therapy. And again, you can see that follow-up is a little bit shorter than the monotherapy cohort, but there are durable responses, only 1 Richter's emergence thus far, and very high response rate and durability looks good as well. Very high undetectable MRD rates, which you can see here in the whole population, 86%. So obviously further follow-up is needed, but at early look, they seem to have a better median duration of response and better median better median progression-free survival thus far. And from the CLL point of view, the summary for me is that CAR T cells targeting CD19 do have the potential to render rapid, deep, and durable remissions in relapsed refractory CLL patients, and combinations with ibrutinib may be even more beneficial. I feel like a little bit earlier treatment than 3rd or 4th line or 5th line in CLL patients, especially for those with high-risk features. The ones we know will progress, and I wish we knew better who are the ones who really would progress repeatedly. But those patients, if they're treated earlier, may actually not have this Richter's emergences and things like that. Switching tracks to B-cell non-Hodgkin lymphoma. So I've been involved with the Zuma 1 trial, which led to the FDA approval of axicabtagene ciloleucel. I've been involved with the Transcend NHL 001 study, which led to the FDA approval of lysocell, lisocabtagene maraleucel. And in all the studies, even the tisagenlecleucel study, which I wasn't part of, but of course we know the data from the Juliet trial, et cetera, we know that in the 30 or 40% patients who do not achieve a complete remission with first-line therapy and then have to be salvaged, and then in third line or beyond get CAR T cells, we're able to save about 40% of those lives using one of these products. However, that means that there are still 60% patients out of those third line or beyond relapsed refractory DLBCL patients who still succumb to their disease, and we need to do better than 40%. So that's one thing. The other thing is some of the aggressive lymphomas, like Richter's syndrome, which emerges from CLL, really we have no answers for. CAR T cells by themselves may or may not work very well. So we think we need combinations to address both those issues. And then a disease like relapsed refractory mantle cell lymphoma, we have seen good responses to CAR T cells there as well, although durability may be about 60% or so with Brexucell. But we also see a lot of toxicity when treating these cells. And so the question is, how can we improve upon that as well? So I don't have all the answers, but these are some of the combination trials that have happened or are ongoing or are coming to try to address some of these issues. So the first one is Zuma Six, which is a phase 1/2 trial of axi-cel in combination with atezolizumab for patients with relapsed refractory diffuse large B-cell lymphoma. And it's a little bit complicated, the study schema, but there were basically 3 cohorts. And the differences were that the start of atezolizumab was either 3 weeks after CAR T cells, 2 weeks after CAR T cells, or basically right after CAR T cells, the day after CAR T cells. And then everybody was followed. And you can see that they had 22 patients on the phase 2 portion. Cohort 3 was the one that went on to phase 2. And the total number of patients there were 28. Median follow-up at the time of this presentation was 10.2 months or so. And not to dwell on it too much, but here are the baseline characteristics of that cohort 3, phase 2 patient population. Median age 58. Majority of patients had advanced stage disease. Some had primary refractory disease. Most of them had several lines of therapy already. And you can see that there were AEs. Everybody had at least one or more AE, as expected. They're all getting flu-cy. They're all getting CAR T cells. And then on top of that, atezolizumab. There was a DLT having to do with cytopenias that lasted for a very long period of time. There was one grade 5 event of multi-organ dysfunction that they thought was unrelated to cells or atezolizumab. And then you can see the different, the breakdown of the different specific side effects. Bottom line, the CRS events were, at least grade 3 or higher, CRS events were not that many. And the grade 3 or higher neurological events was, 29%, which is what we expect with axi-cel. And then the responses are shown here, 75% overall response rate. Again, not a very large number of patients, but encouraging, 46% were complete remissions. And of course, the duration of response is the biggest thing, and the progression-free survival, so that will need to be followed. But at least as of 6 months, the duration of response and PFS had not been reached thus far. So the authors concluded that atezolizumab combined with axi-cel did not affect the safety profile adversely. They, however, did not They, however, did note that the sample size was small in the patients where they did see CAR T persistence. And the sense is that the longer you go, because of the atezolizumab in the mix, you may have a longer persistence of those CAR T cells, but they do need to follow patients longer and tell us that essentially. The second study is liso-cel again, which is part of a platform trial, which is still ongoing. And the platform trial has many different cohorts. This was the first cohort of combining liso-cel with durvalumab, another PD-L1 antibody. And I presented this data from this cohort like several years ago at ICML in Lugano in 2019. And we haven't seen more data since then, probably because of the pandemic. But I've asked them to give us updates next year on not just this arm, but also on the completed cohort for combining with ibrutinib in aggressive lymphomas. There are a couple of other arms, one combining with nivolumab, which is more commercially available than durvalumab, and then also another one combining with a cereblon inhibitor. We don't have data on that yet because those cohorts are still ongoing with accrual. But again, the bottom line is that, which I've already mentioned before, that with Transcend NHL 001, you can see that the durability or the median progression-free survival there is a plateau at about 40% or thereabouts in most of these CAR T cells that are commercially available. So there is room to improve, and therefore combining with a PD checkpoint inhibitor makes sense because you want to see if you can enhance not just the efficacy but also the CAR T persistence and the CAR T expansion by using these combinations. So the platform trial, this was the first cohort combining with durvalumab. There were a couple of different cell doses tried, and then everybody got several months of durvalumab over time. And these are the key eligibility criteria. Basically, relapse refractory diffuse large B-cell lymphoma of any sort was allowed or is allowed. Even prior transplant is allowed. No active CNS disease, however. And this is the consort diagram. So in the end, it turned out that 8 patients got liso-cel plus durvalumab in cohort 1A, and then 6 out of 8 got in cohort 1B. Basically, there were 16 patients who got their study treatment or liso-cel infusion, but the product was made for 20 patients, so 4 fell off along the way, 3 because they had rapid progression of disease, and 1 because they actually achieved a complete remission with radiation. So they couldn't be eligible to get their CAR T cells. Median age of these 16 patients who did get their liso-cel treatment was 65.5. You can see the breakdown of the different types of histologies there on the left, and whether they were refractory or relapsed. 44% patients received bridging therapy during manufacturing. I just wanted to show this, that there was no effect on CRS or neurotoxicity by adding the durvalumab. There was very little high-grade CRS or neurotoxicity at all, which we've seen with liso-cel fairly commonly. The overall response rates are shown here for the different cohorts, but the total one you can see on the left that basically 93% of the patients who were actually treated with liso-cel had an overall response, with 79% being complete remission. If you look at the ITT population, this would be 12 out of 20. So obviously the percentage would be a little bit lower, but it's important to just know that it's good to get people to the CAR T cells so they can have the better responses. And then this is the durability of the response of the combination treatment. So 79% patients had a CR, like we just saw, and majority of them maintained their CR for a long period of time. I had one patient with Richter's syndrome on this cohort, and she basically never relapsed with her Richter's for 2 years beyond CAR T cells, which is very rare to see with Richter's. But she unfortunately developed MDS because of all the prior chemotherapy she'd had, including the Flu-Cy, and unfortunately died of complications of myelodysplastic syndrome. Just a little bit about the PKs. So you can just see that the expansion was not really affected by the durvalumab, although if you compare it to monotherapy from Transcend NHL 001, it looks like there might be a trend for higher CAR T cell numbers and persistence with the durvalumab in the mix. And so that's sort of what we're trying to get at with checkpoint inhibition, combining with CAR T cells. So this is the summary for the durvalumab combination. There were no dose-limiting toxicities. The rates of CRS and neurotoxicity were not any different than the lysocell monotherapy studies. The overall response rate was pretty high in the patients who did get treatment. And we want to be able to see how durable these responses obviously are, so that data hopefully should be coming next year. And then persistence may be better in the combination arm. And just to round it off with a couple of other ideas that we're working on. So Richter's syndrome in CLL is basically, as a CLL physician, it's basically sort of the bane of our existence. Once patients develop Richter's, we really don't know what to do with them. We try many different things. We try anthracycline-based chemotherapy. Doesn't really work all the time. We've tried to combine that with a novel agent, BTK inhibitor or venetoclax, and sometimes that works, sometimes it doesn't. There's been data to show that nivolumab plus ibrutinib may have some responses, 40–50% responses that can get people bridged over to an allo transplant if you have a donor lined up for them and if they're healthy enough to go for allo. But we don't really have a good answer to Richter's syndrome. And so in conjunction with MD Anderson, I'm opening a study at City of Hope fairly soon, which is going to combine all three things, so lysocell CAR T cells, ibrutinib, and nivolumab, and we'll see how that works for Richter's specifically. At our center, my colleague Elizabeth Buddy is investigating the combination of our City of Hope CD19 CAR T cells with acalabrutinib in relapsed refractory mantle cell lymphoma. And so we'll see how that looks. Interestingly, there's not a lot of data in how the novel BTK inhibitors partner with CAR T cells. Ibrutinib works extremely well because of the effects on T cells and the ITK pathway, et cetera. I'm not sure how well acalabrutinib or zanubrutinib and others might work. There may still be some benefit, but we'll see what this with this data shows, at least in mantle cell lymphoma. And so, just in conclusion, I think we've certainly seen a lot of improvements in patient lives with DLBCL, et cetera, and mantle cell with the advent of CD19-directed CAR T cell therapy, but there's still a lot of improvement to be done, and that's where all the ideas we heard about today and then the combinations we're working on will hopefully help. And I think every year we'll get more and more news about how we can improve upon what we've already studied. So with that, I will end. Thank you.